Starting with the second topic, guys, in neuro-ophthalmology, pupillary reflexes. Again, one of those topics which students skip studying altogether in the third professional year because they find it very difficult. We can't comprehend it. But again, to comprehend it, what do we need is concept. And again, I will say that the concept is very easy. Just grasp it once. What are we trying to study when we are trying to study about pupillary reflexes? We are trying to study whether our pupil is normal or abnormal. Yes, normal means it will be able to constrict as well as dilate, and abnormal means either a problem in constriction or a problem in dilatation. So, how do we elicit pupillary reflexes? Number one, near reflex. Now, near reflex by the name itself is pretty clear, the changes that take place in the eye when we look at a near object. We have already studied about it in the anatomy of the eye chapter. It consists of three parts: accommodation plus convergence plus meiosis. So accommodation we know, convergence we know, meiosis we know. So meiosis is the part which is of the pupil. That means the pupil constricts when we look at a near object. Number two, ciliospinal reflex. Ciliospinal reflex is ipsilateral dilatation of pupil if pain in neck/trunk. What do I mean to say? Or as a response? Yes, as a response to me pinching my neck here, pain is generated, everybody. My ipsilateral pupil will dilate, everybody. Ciliospinal reflex. So as a response to the pain in neck or trunk, everybody, my pupil will dilate. Thirdly, psychosensory reflex. Psychosensory reflex is basically again dilatation of pupil in response to stress. Whenever we are stressed, our pupils tend to dilate. Okay. Now, you may remember that ciliospinal reflex is lost in Horner's syndrome. I hope you remember the mnemonic MAPLE, maple, everybody. L for loss of ciliospinal reflex. So the pupil is not able to dilate in response to the pain generated on pinching in the neck or the trunk. Am I absolutely making myself very clear? Yes. Now we come on to the main reflex, so as to say, which we can call the light reflex. Now, what is light reflex, everybody? All of us know that when light is shown onto the pupil, or when we are standing in sunlight, everybody, our pupils constrict to control the excess amount of light that may enter our eye. And when we are in a dark or when we are in night, everybody, our pupils dilate in order to allow more light to come inside the eye. So this is basically light reflex, constriction of pupil in response to bright light or dilatation of pupil in response to dim light. Now the question comes into my mind, everybody, how does the pupil movement get controlled? The pupil movement gets controlled through a complex pathway, which obviously starts from the optic nerve, because at last all the light falls onto the retina and then gets conveyed to the cortex. Yes, it's a reflex. So it will be the afferent arm and then the efferent arm. The efferent arm will come and it will innervate the muscles of the iris, the sphincter pupillae or the dilator pupillae. But before that, everybody, let's discuss the clinical part before we move on to the anatomical part. A patient comes to me and I want to see whether the pupil is functioning normally or abnormally. That means I need to test the light reflex. How do I test it? Do I ask the patient to go out into the sunlight and go with him to check whether the pupil is constricting or not? No. How do we do this test? This is a dark room procedure, everybody. We ask the patient to sit in a dark room for 5 to 10 minutes. which is sufficient time to be able to dilate the pupil fully. Yes. Then we ask the patient to hold his or her hand between the two eyes. We have to check each eye individually, everybody. We take a torch light, we throw light on one of the eyes. In this case, I am throwing light on my left eye. We see whether the pupil is constricting or not. If we throw light, the pupil should constrict. Yes. So the scenario is that the left eye, light is being thrown, the right eye remains in dark. So what do we expect? We expect that the left pupil will be constricted and the right pupil will be dilated because it is in dark. But does it happen like this? No. Actually, what happens is, as soon as we throw light on one eye, everybody, the pupil of that eye constricts, as well as the other pupil, that also constricts, everybody. So what am I trying to say? I am trying to say that light reflex is of two types. One I am calling as direct light reflex, and the other we are calling as consensual light reflex. Okay. Now let's see this through an image. In this image, we are throwing light on the right eye of the patient. What do we see? That upon throwing light on the right eye, the right pupil constricts. But we see that the left pupil also constricts. Please remember, there is no light on the left eye. So that means light thrown on one eye, but constriction of pupil of both the eyes. This is direct light reflex. That means constriction of pupil, which is illuminated by light. The contralateral pupil, which was not illuminated by light, but which also constricted, that gets the name as consensual light reflex. Consensual means by its own will, apni marzi se. Am I clear? So let's write this, everybody. Direct light reflex is constriction of ipsilateral pupil, or I can say pupil which has been illuminated by light. Whereas consensual light reflex is constriction of contralateral pupil which was not illuminated. I hope I'm pretty clear here that even if I throw light only on one of my eye, both the pupil are going to constrict. On the same side, I'm calling it direct. On the opposite side, I'm calling it consensual light reflex. Okay. We know that this is going to happen. We know it is a dark room procedure. So how are we going to test it? But the question which I'm asking myself right now is, why is this occurring? Even though I'm throwing light on one eye, why is the other eye which was in dark, why is that pupil constricted? So answer that, everybody. Now we look at the pathway. The pathway for light reflex. Okay, everybody. So let's see. Again, I will like to reiterate that we draw pathways for ourselves. So this is the left side on the left eye. This is the right side on the right eye, everybody. Yes. Now we have thrown light on the right eye as being denoted by the arrow. The light will first fall onto the retina. From the retina, light will go into the optic nerve. From the optic nerve, it will go into the temporal part of the optic chiasma. From the optic chiasma, it will go into the optic tract. Right eye, right optic nerve, optic chiasma, temporal part, right optic tract. So till now we see similarity from the visual pathway, everybody. Optic nerve, optic chiasma, optic tract. But this is where the similarity ceases to exist. From the optic tract, if we remember, the visual fibers, everybody, would have gone to the lateral geniculate body. But the pupillomotor fibers, what are we calling them, everybody? Pupillomotor fibers, because they are responsible for the movement of the pupil, the constriction or the dilatation. They leave the optic tract, as you can see here. Keep following my black line, everybody. And instead of going to the lateral geniculate body, they go to a new place, and that new place is called as pretectum. nuclei. That new place is called as pretectal nuclei. Very important part, because we call it the center for light reflex. We call it the center for light reflex. Am I absolutely clear? So till now, if you see the pathway, let's assume this is my right eye, everybody. So I've thrown light on the right eye, right optic nerve, optic chiasma, right optic tract. From right optic tract, instead of going to the Edinger-Westphal nucleus, the fibers leave and go to the right pretectal nucleus. Till now clear? Now, from the right pretectal nucleus, everybody, that is where the magic happens, you can say. From the right pretectal nucleus, follow these yellow lines, everybody. We see that the impulse travels to the right side as well as it travels to the left side Edinger-Westphal nucleus. So the impulse which was only on the right pretectal nucleus is getting split into two parts, traveling to the right, that is the ipsilateral Edinger-Westphal, as well as the left or the contralateral Edinger-Westphal. If we understand this, do we understand this is where the impulse is splitting? This is what will lead to direct as well as consensual light thrown on one eye, but both the pupil getting constricted, everybody. So these neurons, everybody, which go to the same side as well as the opposite side, these are known as internuncial neurons. If you understand the name, everybody, internuncial. Internuncial means connecting to nucleus, pretectal nucleus and Edinger-Westphal nucleus. Now, half of them curve around periaqueductal gray and go to the ipsilateral Edinger-Westphal nucleus. Half go through the posterior commissure to the contralateral Edinger-Westphal nucleus. Okay, so they are going half to the ipsilateral, half to the contralateral Edinger-Westphal nucleus. So ultimately, the pupilomotor impulse has reached both the Edinger-Westphal nucleus, ipsilateral as well as contralateral. Now, all of us should remember through anatomy, Edinger-Westphal nucleus is the accessory nucleus for which cranial nerve? It is the accessory nucleus for third cranial nerve. Yes, guys. So from the Edinger-Westphal nucleus, now the third cranial nerve, everybody in green here, will go up, everybody, to the ciliary ganglion. Third cranial nerve goes up to the ciliary ganglion. Oculomotor nerve, inferior branch to inferior oblique, everybody, as we had studied in Horner syndrome in anatomy chapter, goes to ciliary ganglion. Then from each ciliary ganglion, the final nerve, which is the postganglionic nerve, that is short ciliary nerve, will go and will innervate both the sphincter pupillae. So the left sphincter pupillae will constrict, the right sphincter pupillae will constrict, both the pupil will constrict. On the same side, I will call it direct light reflex. On the opposite side, I will call it consensual light reflex. I hope I am clear about the pathway. If not, let us revise it very quickly here, everybody. Let's see, first I am writing it. Optic nerve, yes. Then see optic chiasma, temporal part, optic tract. From optic tract, we go to pretectal nuclei. Remember, right optic nerve, optic chiasma, right optic tract, right pretectal nuclei. From right pretectal nuclei, internuncial neurons take it to both the Edinger-Westphal nucleus. From both Edinger-Westphal nucleus, what will occur? Respective third nerve will go to ciliary ganglion. From the ciliary ganglion, short ciliary nerve will ultimately innervate the sphincter pupillae, and thus both the pupil will constrict. I hope I'm clear, everybody. For the last time, everybody see my hands: optic nerve, optic chiasma, optic tract, pretectal nucleus, both Edinger-Westphal, both oculomotor nerve, both ciliary ganglion, both short ciliary nerve innervating sphincter pupillae, both pupil constrict. I hope I'm pretty clear here. Again, you should be able to remember it, everybody. Use your hands, use your words, and use your mind, everybody. Yes? Now, it is a reflex. So we have to see that there is an afferent nerve and an efferent nerve. So what is the afferent nerve, everybody? Second nerve, the optic nerve, afferent pathway coming in. What is the efferent pathway? Oculomotor nerve, third nerve forming the efferent pathway, everybody. So this is a very simple question which can be asked. I hope you do remember it. I hope you understand that the center of light reflex is pretectal nuclei. Now the question which sometimes can be asked to you, which structure is responsible for consensual light reflex? So I'm writing this question. Structure for consensual light reflex. See, the best answer in this will be, as we just now understood, I hope, internuncial neurons. But if internuncial neurons is not given in the options, which generally is not, then the second best answer will be Edinger-Westphal nucleus. Okay, internuncial neurons dividing, the recipient is Edinger-Westphal nucleus. So please see the options carefully and please answer this question. Structure responsible for consensual light reflex. Are we clear about this, everybody? So light reflex is of two types, everybody. Again, direct light reflex on the same side, consensual on the other side, and the pathway for it. Now comes the question, everybody, again into my mind. This is a pathway. If this is a pathway, there are going to be some lesions in it. Lesions, though, let's study afferent pathway defects. So because there are two pathways, afferent and efferent, we divide the lesions into two parts. Afferent pathway defects affecting the optic nerve, optic tract, optic chiasma till the pretectal nuclei. And efferent starts from the third nerve onwards. Yes or no? Edinger-Westphal nucleus onwards. So those will be the efferent pathway defects. Ready, guys? Let's start. This is the part students find most confusing, but it is very easy. Easy because you already now know the pathway for light reflex. So afferent pathway defect number 1. We can call it AAPD. We can call it TAPD. Or we can call it amaurotic pupil. Okay. Now, A for absolute. T for total. What are we trying to say here? APD, you understand? Afferent pathway defect. Absolute afferent pathway defect. Total afferent pathway defect. Okay? We are trying to say that the afferent pathway is lesioned or is lost in totality. It is not functioning at all. Based on this and your common sense and your English knowledge, if I ask you what is the cause of AAPD or TAPD, I think it will be very simple to say complete optic nerve lesion. Can I say this? Complete optic nerve lesion. Optic nerve is the afferent pathway. Absolute means something which is complete in total, everybody. So the answer becomes complete optic nerve lesion, which may occur in cases of end stage optic atrophy or in cases of severe trauma. Am I absolutely clear? No confusion here? Now, what will be the light reflex findings? Okay. Now, to understand the light reflex findings, let's use the image and try to understand. So let's see this set of image. The first image, everybody. This is on presentation. The patient has come to your clinic. You have not done any test till now. You're just observing the pupil, both the pupil of the patient. Okay. On presentation, what do we see? We see that both pupil are of equal size. Do we see this? Yes or no? Yes. But let's assume that I am writing here, assume right eye optic nerve complete lesion. I'm saying that this patient is actually a known case of right optic nerve lesion. Still, I am saying on presentation, both pupil look similar. Why is that so? See, the patient must have been coming from outside. Outside, let's say there is sunlight. Okay. So, right eye optic nerve is lesion. Forget the right eye. Focus just on the left eye and see, everybody, what will happen. The light which was falling on the left eye will go into the left optic nerve, left optic chiasma, left optic tract, left pretectal nucleus, both Edinger-Westphal, both oculomotor nerve, both ciliary ganglion, both short ciliary nerve, both pupil would be constricted. Forget whether right eye is functional or not. We are saying right eye is non-functional, right optic nerve lesion. Just due to the left optic nerve and the sunlight falling into it, both the pupil would have been constricted. Both the pupil on presentation to you would be of equal size. When both the pupil are of equal size, this is known as isochoria. This is known as isochoria. So that means the clinical feature at presentation, everybody, in case of AAPD is isochoria, an MCQ in itself. Am I making myself very clear? Please remember, iso means same, choria means pupil. So same sized pupil. Now, once we saw this, then we decided to test our light reflex. Okay. So we first have thrown light on normal side. In this case, the normal side is the left eye. I hope we are clear. We have assumed right eye optic nerve lesion. So our left eye is the normal eye. Now, as soon as we have thrown a torchlight, everybody, you can see on the left eye, what do we see? That both the pupil have constricted further due to light on left eye. Again, the same pathway: left optic nerve, left optic chiasma, left optic tract, left pretectal nucleus, both Hedinger-Westphal, both oculomotor, both ciliary, both short ciliary nerve, both pupil get constricted. So I say both pupil constrict. Is there any confusion in this? I hope no. Normal. Now we say light on lesion site. In this case, we have assumed that the lesion is in the right eye. Now let's see what will occur. The patient was holding his hand, you threw the light on the left eye, both the pupil constricted. All right. Now you took the torch to the right eye. In right eye, everybody, optic nerve is lesion. So as soon as you throw light on the right eye, the light falls onto the right eye, right retina, right optic nerve. But the right optic nerve is cut. That means the light cannot go down. That means the pathway is cut. That means the pathway is stopped. So will any of the pupil be able to constrict, everybody here? Will any of the pupil be able to constrict? Right optic nerve cut. Not going down, not going to pretectal, not coming back, everybody. That means both the pupil, yes, very good guys, both pupil do not constrict. Am I making myself very clear here? Yes. So it is as simple as when you throw light on the normal eye, both pupil constrict. When you throw light on the lesion side, both pupil do not constrict. If we note, everybody, whether both pupil constrict or both pupil do not constrict, both the pupil always act together in unison. They are always of the same size. So if you ask me, sir, what are the clinical features of AAPD? The first thing I will say is isochoria. Always isochoria. At presentation and even on testing the light reflex. Am I pretty clear here? Number two, everybody. This is a lesion of what, everybody? Complete lesion of optic nerve. Think back to the first part of the neuro-ophthalmology, everybody. Visual pathway lesion number one, optic nerve. If the optic nerve is cut, what will it lead to, everybody? Ipsilateral anopia. Yes or no? Isochoria, ipsilateral anopia. Number three, light reflex is absent. Now, which light reflex is absent? If you want to say, everybody, we are throwing light on which eye? Right eye. Okay. Where is the lesion, everybody? Right side. Are you listening to me? The side of lesion is the right side. Okay. So that means right eye becomes the ipsilateral eye. I am writing right ipsilateral, left contralateral. Very important. A lot of students get confused here. Laterality is defined by the site of lesion. So the lesion is on the right side. So any finding in the right eye will be considered an ipsilateral finding. Any finding in the left eye will be considered contralateral finding. Again, I will repeat. Side of lesion determines the laterality. Okay, everybody? Clear? Now, see the third photograph, everybody. We were throwing light on the right eye. Right pupil was not responding. Right eye, right pupil. Which reflex does it become? Light, light on right eye, direct light reflex. So I say ipsilateral direct light reflex is absent. Can I say this, everybody? Yes or no? When I throw light on the right eye, the right pupil does not constrict. So that means it is direct light reflex. Because the site of lesion is also the right eye, it becomes ipsilateral. When I throw light on the right eye, the left pupil also does not constrict. That means it is which light reflex? Consensual light reflex. And because the site of lesion is the right eye, the left eye becomes contralateral. I hope I'm pretty clear here. Yes? Now, lastly, everybody, near reflex is still present. Near reflex is still present. So these are the clinical features or the findings of a case of AAPD. If you want to summarize it, if you want to revise it, just focus on the name absolute. Absolute means complete, toto. So when you throw light on the left eye, both pupil constrict, the normal side. If you throw light on the abnormal side, both pupil do not constrict. Am I pretty clear here? Yes, sirs. Done. Okay. So let's move on, everybody, to the next lesion, everybody. Lesion number 2, guys. Lesion number 2 is known as RAPD, also known as Marcus gun pupil. Marcus gun pupil is the famous name which you will encounter in a lot of questions. And as per my experience, as soon as students here read this name in a question, they leave this question. Why? Because they have not read it, not understood it, and that is what we are going to do here, everybody. So first of all, what is the full form of RAPD? APD, we understand, afferent pathway defect, and R for relative. So I hope if you understand English, this becomes pretty clear. A for absolute. Absolute means something which is complete. Relative. Relative means in relation to AAPD, it is an incomplete lesion. So that is where I ask you, what are the causes? So in causes, I say I have a case of incomplete optic nerve lesion. Now, what do you mean by an incomplete lesion? Incomplete lesion means that optic nerve, a disease is active. It has started. It is harming the function of the optic nerve. It is not letting the optic nerve perform to its optimum potential. But still the optic nerve is functional. You understand my point? We have not lost the optic nerve. Some of the function of optic nerve is still left. So let's say a patient is suffering from optic neuritis. Optic neuritis is inflammation of optic nerve. Yes. So inflammation of optic nerve, some of the part of optic nerve is not functional. So we are saying it is an incomplete optic nerve lesion. Similarly, the second cause can be a case of retinal detachment. Retina, nerve fibers, yes, axons of ganglion cells form the optic nerve. So if the axons of ganglion cells are forming the optic nerve, but the ganglion cells are not functional, the axons will also not be functional. So whichever part of retina is detached, that part of my optic nerve is not getting the impulse. It is non-functional or partially functional. Lastly, the causes can be CRAO or CRVO, that is central retinal artery occlusion or central retinal vein occlusion. So all these can lead to an incomplete optic nerve lesion, where the optic nerve is partially functional and partially non-functional. I hope you understand the difference from AAPD. Now, let's see what will be the light reflex findings in this. Okay. Again, let's use some image. Similar image, everybody. Similarly, like in the previous case, we say assume a right optic nerve lesion. But obviously this time we are assuming a partial lesion because we are discussing case of RAPD. Now again, the first photograph on presentation. On presentation, I hope again we don't need to go through the whole pathway again. If we need to, I will go again. Right optic nerve has some lesion, forget the right eye, focus on the left eye. Left optic nerve, optic chiasma, left optic tract, left pretectal nucleus, both heading nerve vestral, both third nerve, both ciliary ganglion, both short ciliary nerve. Same thing again and again. That means both pupil are of equal size. We know equal size is isochoria. Next, everybody, the second photograph, we are again throwing light on the normal side first. Normal side, again, we are saying is the left eye. Okay. So we are throwing light on the left eye. When we throw light on the left eye, what will occur? What will occur? What will occur? Yes, we have said it so many times. Both the pupil will constrict, sir. Yes, they will constrict. So both pupil constrict. Till now, if you see, everything is the same as AAPD. That means the difference has to come when we throw light on lesion side. And lesion side is the right eye. Yes. As soon as we have thrown light on the right eye, based on the image, what can you see? We can see that both the pupil have dilated. Yes or no? So let me write, both the pupil dilate. But the question comes, sir, why do both the pupil dilate? That is what we want to answer here. So before we answer that, I will ask all of you a question, everybody. Have you ever heard of something which can be used to test RAPD? A very important test, everybody, a very important viva voce question, everybody commonly asked. A test which is used to diagnose RAPD. A test, see, I'm showing you the test. Can you see the test? Yes, I know you know the test. Sir, swinging torchlight test or swinging flashlight test. Yes. So that is where the understanding of RAPD comes. Let's understand a case of RAPD. Right eye is partially functional, left eye is fully functional. So when I do this test, why throw light on the left eye first? Both the pupil constrict because the left optic nerve is absolutely normal. The left pathway is normal. Then I bring my torchlight to the right side. Right side, the optic nerve is partially functional. Yes or no? Yes. Because it is partially functional, what will occur? Light will fall onto the right retina. It will go into the right optic nerve. But it is partially functional. So from the right optic nerve, the impulse will travel down optic chiasma, optic tract, pretectal nucleus, both Hedinger-Westphal, both oculomotor nerve, both ciliary ganglion, both short ciliary nerve, both pupil will constrict. When I threw light on the normal side, both pupil constricted. When I threw light on the lesion side, again both pupil constricted. But sir, you have written both pupil dilate. You are explaining both pupil constrict, but you have written both pupil dilate. Why so, sir? That is where swinging flashlight test comes into effect. We don't just do it once. We swing. We threw light on the left eye, both pupil constricted. We threw light on the right eye, both pupil constricted. We again swing the torch back to the left eye. Both pupil again constrict. Again go back to the right eye. Both pupil again constrict. We keep doing this 5 or 6 times. We keep doing this 5 or 6 times. Both the pupil constrict left eye, both the pupil constrict, light on right eye. Why are we doing this swinging? We are doing this swinging in order to fatigue the right optic nerve. See, there are two optic nerves, left and right. Left optic nerve is normal, so it will get fatigued much later. But the right optic nerve, everybody, which is lesioned, partially functional, will get fatigued earlier. Yes or no? Yes. So once we have done this swinging 5 or 6 times, everybody, my right optic nerve has gotten fatigued now. Now what will occur? As soon as I throw light on the left eye, pupil will constrict. Okay. So let's see, everybody. Just making a small diagram. This is my left, this is my right. Okay. Patient's eyes. As soon as I threw light on the left eye, both my pupil constricted. Now to swing, everybody, I will bring the torch here. See, everybody, I am not doing this. I am doing this. Why am I doing this? Because when I bring my torch here, for a period of 1 to 2 seconds, both the eyes are in dark. When both the eyes are in dark, both the pupils start to dilate. Can I say, everybody? Both the pupils start to dilate. Then my torch reaches the right eye. Now, as soon as light has to fall onto the right eye, the pupil should again constrict. But because the right optic nerve is already fatigued, so the impulse it sends for constriction is very weak. It is weaker than the impulse for dilatation, which is already present due to the darkness. So what do I see? As soon as I bring my torch from the left eye slowly to the right eye, I see instead of constriction, both the pupil are dilating. And this is RAPD or Marcus Gunn pupil. So why are we doing the swinging flashlight test? To fatigue the lesion nerve. When the lesion nerve gets fatigued, the impulse for constriction becomes weaker than the impulse for already occurring dilatation. Do you understand this concept? If yes, let's write everybody. Now, I am saying RAPD is elicited on swinging flashlight test. On repeated testing, lesioned nerve, in this case the right optic nerve, gets fatigued earlier than normal nerve, that is the left optic nerve. Thus, A, light on left eye, both pupil constrict. Then B, on withdrawing light, both pupil start to dilate and then ultimately when we reach the right eye, light on right eye, impulse for constriction is weaker than impulse for dilatation, which was already occurring in step B, everybody. Thus, pupil dilate, known as pupillary escape phenomena or paradoxical dilatation. See, understand the meaning of the word paradoxical, everybody. When we are saying paradoxical, we are trying to say paradox means something which is opposite. We normally expect that when we throw light on any pupil, the pupil should constrict. Here, the opposite is happening. That means dilatation is happening. And that is why it gets to be known as paradoxical dilatation. Or we are saying the pupil is escaping, everybody, escaping the constriction phenomena and instead is dilating. So we are calling it the pupillary escape phenomena. So I hope now you understand more than the name of the test. Yes, we know that swinging flashlight test is done, but now we also know why it is done. So that means if any case comes to you, you should always do a swinging flashlight test to rule out whether it is RAPD or not. Because if you do this test only once, you think it is normal, you may be missing a very important finding, everybody. Yes? To explain RAPD to you further, let's play a video. In this video, everybody, you will be able to see that now that we have thrown light on the left eye, the pupil has constricted. But as soon as we bring the light to the right eye, the pupil has started to dilate. Let's see this phenomena again, everybody. Left eye constrict, right eye dilate. Left eye constrict, right eye dilate. Left eye again constrict, Right eye again, dilate. Obviously, you can only see one eye here, but this will be happening in both the eyes. That means the left eye is normal in this case. Both the pupil are constricting. But once we are moving to the right eye, both the pupil are dilating. And this is an example of RAPD. I hope all of us are able to understand this video here, everybody. Please, whenever you go to your postings, try and see if you can find out RAPD in any case. It is a very important thing to be able to learn as a clinician, guys. Okay. Now, what we understand from RAPD again is whatever happens in both the pupils together. That means just like AAPD, RAPD will always present with isochoria. Am I making myself very clear here, everybody? Yes, sir. So these are the two important afferent pathway defects that we just now saw, AAPD and RAPD. Now, moving on, everybody. The third afferent pathway defect that we know or can read about is Wernicke's hemianopic pupil. If you remember, we have read it somewhere. Yes. Differentiation between optic tract, LGB, and optic radiation lesion. What is the site of lesion? The site of lesion is optic tract. If you remember differentiation between lesion number 5, 6, and 7, we had said that in 6 and 7, that is LGB and optic radiations, the pupil is normal, but the pupil is abnormal, Wernicke's pupil, in cases of optic tract lesion. Why is it so? If you understand the pathway, you understand. The pupillomotor fibers go from the optic nerve, optic chiasma, optic tract, but they do not go to the lateral geniculate body or the optic radiations. So whenever there is an optic tract lesion, it will lead to visual field defect as well as pupillary defect. But LGB, because it does not have pupillomotor fibers, or optic radiation, because it does not have pupillomotor fibers, there will be no pupillary lesion. Now, what happens in this? Light reflex. So to explain you this, I will draw the visual field defect of optic tract. Do we remember, guys, what was the visual field defect of optic tract? I am saying right optic tract lesion. Anybody? Do we remember? Guys? Do we remember? Yes, we do. Optic tract, below the optic chiasma, contralateral homonymous hemianopia. Contralateral means both eyes. Which visual field will be lost? The left visual field will be lost. Okay. So this will be the visual field presentation. Now, in this case, what will occur? If I throw light in any of these two quadrants, this is my left visual field, this is my right visual field. Okay, everybody, you understand this? So if I throw light in any of the visual fields in which hemianopia is there, pupil will not constrict. I am calling it point A. So point A, light thrown in hemianopic visual field which is lost in any eye, pupil do not constrict. Okay, everybody. So if I throw light on the left side in any of the eye, pupil will not constrict. But if I throw light here, or if I throw light here, I am terming it point B, then both the pupil will constrict. So I can say point B, if light is thrown in hemivisual field which is present, both pupil constrict. If we write it, it becomes very long. If we understand it, it becomes very short. The hemianopia side, whether the left side or the right side in both the eyes, throw light, no pupil constriction. The visible part, both eyes, pupil constrict. As simple as that, everybody. Yes, I don't think anybody will ask you what is Wernicke's pupil. They will at most ask you Wernicke's pupil is due to lesion of, or how to differentiate between optic tract, LGB, and optic radiation, right? That's all about afferent pathway defects from my side. Now we move on to the second part of the lesions in the pupillary reflex, that is the efferent pathway defects. Afferent pathway done. Now we move on to efferent pathway. In efferent pathway, the first thing that comes into mind is ARP. We have heard this name many a times. We have heard this name. The full form is Argyll-Robertson pupil or Argyll-Robertson pupil. Point number one, which diseases cause ARP? The first disease is very famous. All of us understand it. You said syphilis. I don't like syphilis. I like, guys, neurosyphilis. Syphilis can be primary, secondary, or tertiary. Primary and secondary syphilis do not cause ARP. Only tertiary syphilis, neurosyphilis, which is a manifestation of the tertiary stage, everybody, only that will cause it. So please do not say syphilis. Please always get into the habit of saying neurosyphilis or tertiary syphilis. The second important cause of Argyll-Robertson pupil can be tabes dorsalis. Again, I hope you understand related. Or third, aortic regurgitation. Okay, now we know the cause. All right. What about the site of lesion? Where in the pathway is the lesion? We are saying efferent pathway, but where is the lesion? So the lesion can be in the rostral midbrain. In the area which we call as periaqueductal gray matter. Or the answer can be posterior commissure. Okay, so any of the two answers are correct. The better answer is obviously A. The second best answer is B. Now the question comes, what do these two sites have to do with our pathway? Optic nerve, optic chiasma, optic tract, pretectal nucleus, Edinger-Westphal, oculomotor nerve, ciliary ganglion, short ciliary nerve. We are not talking about any part. We are talking about a region. What does this region have to do with us? So this region has to do with a very important part, everybody, which was internuncial neurons. If you remember, we read internuncial neurons half curve around periaqueductal gray, half go through posterior commissure. That means now the lesion is in this part, the very important part which connects the pretectal nuclei to the Edinger-Westphal. So this connection of the ipsilateral and the contralateral is lost. So basically we are saying that the impulse is coming up to pretectal nuclei and it is not going forward. So what is going to occur if you understand? I throw light on the left eye, optic nerve, optic chiasma, optic tract, left pretectal nucleus. The impulse does not go forward. Both pupil do not constrict. I throw light on the right eye, right optic nerve, optic chiasma, optic tract, right pretectal nucleus. Now the impulse does not come forward again. That means both the pupil again do not constrict. Meaning what, everybody? Meaning, if I can say so, clinical feature number one, bilateral light reflex is absent. There is no light reflex whether you throw light on the left eye or on the right eye. But again we say the near reflex is present. Light reflex is absent and the near reflex is present. Wherever such a scenario occurs, we call it light near dissociation. Light near dissociation, normally both these reflexes should either be present or both reflexes should either be absent. In this case, light reflex is absolutely absent and near reflex is present, which is usually learned through a mnemonic. The mnemonic is the name of the disease, ARP, and when you reverse it, it becomes PRA. What does it mean? A for accommodation, the main part of near reflex. So we are saying accommodation reflex is present, but the pupillary light reflex is absent. Okay, everybody, are we clear about this? Yes? Now, third clinical feature, everybody. ARPPRA, very easy, very old mnemonic. I hope you will be able to learn this. There should not be any confusion in this whatsoever. Accommodation reflex or the near reflex is present and the light reflex or the pupillary light reflex is absent. Clinical feature number 3. Pupil does not respond to either miotics or mydriatics. Mydriatics like atropine, miotics like pilocarpine. The pupil will not respond to any pharmacological miotic or mydriatic. And lastly, pupil on presentation are bilaterally constricted. Now, this is a point which confuses me a lot. And I hope it confuses you also a lot. You will have a confusion, then only I'll be able to clear it. So why do you have the confusion first of all? Number one, we are saying light reflex is lost. When we are saying light reflex is lost, that means the pupil cannot constrict, can they? No. But we are saying on the other side that on presentation, both the pupil are constricted. Why this doctrine? The pupil cannot constrict to light, but yet on presentation, they are bilaterally constricted. Why is this so? This is so because the lesion is in rostral midbrain. When there is a lesion in the rostral midbrain, it also lesions the supranuclear inhibitory fibers to Edinger-Westphal nucleus. What does this mean? This means that the Edinger-Westphal nucleus is not receiving any inhibitory impulse. Because it is not receiving any inhibitory impulse, it is continuously sending signals into the oculomotor nerve. See, every nucleus has to have an inhibitory impulse to stop the impulse that it sends. But because the inhibitory impulses are lost, Edinger-Westphal nucleus keeps giving impulse to third nerve, from third nerve ciliary ganglion, then short ciliary nerve, and thus both pupil remain constricted. Are you understanding what I am trying to say? So in actuality, though, it is a loss of constriction, but if you understand due to rostral midbrain, it is actually a loss of dilatation as well as constriction. Because of the continuous impulse generated by the EWN due to the loss of inhibition, everybody, pupils remain constricted. So neither are they able to dilate, and neither, if dilated, they will be able to constrict. It is a fixed pupil, we say, Argyll-Robertson pupil. Please remember the fact that whatever occurs in Argyll-Robertson pupil, the word you can't forget is bilateral. That it is a bilateral manifestation. Am I absolutely clear about this? Yes, sir. Okay. Now, just as a fun fact, you can say, or an extra added edge, there is something called as inverse ARP. In inverse ARP, it is opposite. The accommodation reflex is absent, whereas the light reflex is present. And the lesion is in occipital, or rather occipitotectal tract. Okay, that's it. Fun fact, everybody. May be asked out of the blue, everybody. That is why fun fact. Not important too much. Now, moving on to the second condition of the efferent pathway defect, a very important condition known as tonic pupil, also known as Adie's pupil. Again, first of all, we are saying that it is an efferent pathway defect. So we need to know which part of the efferent pathway is getting lesion, site of lesion. So the answer is either ciliary ganglion or short ciliary nerve. Any of the two parts are getting lesioned. Edinger-Westphal nuclear, oculomotor nerve, ciliary ganglion, or short ciliary nerve. So the ganglion or the final post-ganglionic nerve. Okay. Now, what are the causes for this? The causes for this are, number one, herpes zoster virus ganglionitis. Herpes virus has a propensity of becoming dormant in ganglions, yes or no? Secondly, trauma, orbital trauma. And thirdly, neuropathy due to diseases like diabetes or alcoholism. Peripheral neuropathy, autonomic neuropathy, everybody. Yes. So these are the important causes of a case of tonic pupil, also known as Adie's pupil. Now, what happens to the light reflex? Let's see, everybody. Again, through a series of images, we again assume a lesion, let's say in right ciliary ganglion. Okay. Now, what will occur on presentation? On presentation, what is occurring? Right ciliary ganglion is lost. Okay. So let's forget the right pathway again, just like we are doing it for the other lesions. Focus on the left pathway. Light is falling onto the, see, I am cutting the right ciliary ganglion here. Okay. Light is falling onto the left eye, left optic nerve, optic chiasma, left optic tract, left pretectal nuclei. Both Edinger-Westphal, both oculomotor nerve, both ciliary ganglion. Left ciliary ganglion is functional. Left short ciliary nerve, left pupil will constrict. But right ciliary ganglion is cut, right pupil will not constrict. So if light is entering only the left eye, only the left pupil is constricting, we say, and the right pupil cannot constrict. But on presentation means the patient is coming from sunlight, so the light must be falling in the right eye also. So let's see the right eye also. Right optic nerve, optic chiasma, right optic tract, right pretectal nucleus. From right pretectal nucleus, both Edinger-Westphal, both oculomotor nerve, both ciliary ganglion. Again, both ciliary ganglion, left ciliary ganglion is again functional, left pupil will again constrict. Right ciliary ganglion is cut, right pupil will not constrict. That means on presentation, even with both eyes open, light falling into both eyes, both pathways are telling us that only the left pupil will constrict, right pupil will not constrict. So I will say on presentation, right pupil does not constrict, left pupil constricted. On presentation, that means I am trying to say both pupil different size. I hope you understand the difference. I hope your bell is ringing in your heads, everybody. It cannot be isochoria, it has to be anisocoria. Okay, so on presentation there is anisocoria. Now the patient comes to you. You ask the patient to hold his or her hand. You throw light on the left eye, which is the normal side, everybody. I just now explained you the pathway. I will explain it to you again. Left eye, left optic nerve, optic chiasma, left optic tract, left pretectal nucleus, both Edinger-Westphal, both oculomotor, both ciliary ganglion. Left ciliary ganglion is functional. Left pupil will constrict. Right pupil will not constrict. Can you see? Left pupil has constricted. Right pupil has not constricted. Now you say, sir, throw light on the right eye again. I will again do it for you. I hold my hand, I throw light on the right eye, optic nerve, optic chiasma, optic tract, right pretectal nucleus, both Edinger-Westphal, both oculomotor, both ciliary ganglion. Left ciliary ganglion, again, left pupil constricts, right ciliary ganglion lesion, right pupil does not constrict. That is what we see. Left pupil constricts, right does not constrict. So basically on presentation, on throwing light on the left side, on throwing light on the right side, whatever be the case, the findings remain the same, that the right pupil does not constrict. The left pupil is always constricted, whether you throw light on one eye or the other eye. So if I summarize, I will say, what is the site of lesion, everybody? What is the site of lesion, everybody? right side. Right pupil or ipsilateral pupil, abnormal, never constricts. Left or contralateral pupil is absolutely normal. Again, I will like to reiterate that the laterality, everybody, is defined by the site of lesion, not by the side we are throwing light on, because the side of lesion we have assumed as right. So the right pupil or the ipsilateral pupil is abnormal, never constricts, whereas the contralateral left pupil always constricts. Okay, are we clear about this? So to summarize, if we say clinical features, number 1, light reflex absent. In which eye is light reflex absent? Right eye. Right eye is ipsilateral. When we throw light on the right eye, it becomes direct light reflex. When we throw light on the left eye, it becomes consensual light reflex. So right eye direct light reflex is also absent. Right eye consensual light reflex is also absent. I hope you understand what I'm trying to say here. Yes, both the reflexes are lost in the same eye, ipsilateral eye. When I throw light on the left side, consensual. When I throw light on the right side, ipsilateral direct light reflex. Okay, everybody? Done. Secondly, near reflex is present but shows slow vermiform redilating movements. Near reflex is present, but once the pupil starts to dilate, it dilates slowly and it is slightly vermiform. Vermiform means it will like this, okay? It will be crawling like a snake from one place to another. That kind of movement is seen, okay? Done. That's all about tonic pupil, also known as Adie's pupil. Now we move on to the next condition, that is pharmacological mydriasis. Now, from the name it is clear that the cause is use of mydriatic agents. Use of mydriatic agents, example, atropine. Okay, so atropine is a mydriatic agent. Let's assume that there is an Indian patient who had some atropine eye drop lying in his cupboard. Indians don't believe in expiry of medicine, guys. So he would have been given that medicine some years back, but he had kept it carefully. Now there is some itching in his eye. He says, oh, I have that medicine, I will put it. So he puts atropine in his right eye. Right pupil dilates. Now as soon as that patient goes out into the sunlight, the patient has photophobia because the pupil is dilated under pharmacological mydriasis. It is not able to constrict to sunlight. So the patient now says, sir, I can't open my right eye, I have photophobia. You go to the doctor asks you, have you put any medicine? You will not say. The doctor will get interested. The doctor will examine you. What will the doctor see on examination? Let's see. So we are saying atropine in right eye. So if atropine in right eye, on presentation, right pupil is dilated, left pupil is normal constricted. Now you test the light reflex. You will throw light on the left eye. Left optic nerve, optic chiasma, left optic tract, left pretectal nucleus, both Hedinger-Westphal, both oculomotor, both ciliary ganglion, both short ciliary nerve. Everything is normal. Left short ciliary nerve innervates left sphincter pupillae, which is functional. Left pupil constricts. But right short ciliary nerve innervates right sphincter pupillae, which is not able to function because it is pharmacologically paralyzed by atropine. You understand what I'm trying to say? So the right pupil will not be able to constrict, but the left pupil will constrict. The same thing will occur when you throw light on the right eye. Right pupil will not constrict, but the left pupil will constrict. So that means if I write ipsilateral right pupil never constricts, but the contralateral left pupil can constrict is normal. What does it look like, everybody? If you see the photograph, see this photograph or see this photograph, What do they look like? Tonic pupil and pharmacological mydriasis look absolutely the same. So I will say presents as tonic pupil. That is where our challenge lies. When such a case comes to us, and if the history is not correct, everybody, and believe me, I've been practicing long enough now, patients do not say, yes, sir, I put an eye drop. You have to get them out of it. You have to scold them to get them out of this. So there is a very big chance that you have two diagnoses at hand. How to differentiate? So what we are saying is light reflex problems plus near reflex is also absent. This is the only condition where near reflex is absent. Why is near reflex absent? Atropine will paralyze the ciliary muscle also, temporarily paralysis of ciliary muscle, mydriatic and cycloplegic. Yes, because of the cycloplegic action, ciliary muscle is paralyzed, so accommodation cannot occur. Accommodation cannot occur, meiosis cannot occur. So what will be there? Near reflex will be absent, everybody. So that is the differentiating factor between tonic pupil and pharmacological mydriasis. I hope you have been able to understand this, everybody. And that's all about my efferent pathway defects. If I want to revise it with you, everybody, in 1 minute, let's see the pathway. Again, I have said it a zillion times already. I know you are bored, but it is important that you say it with me now. Optic nerve, optic chiasma, optic tract, pretectal nucleus, center of light reflex. From the pretectal nucleus, internal neurons go to the ipsilateral Edinger-Westphal as well as the contralateral Edinger-Westphal. From each Edinger-Westphal oculomotor nerve, efferent nerve goes up to each ciliary ganglion. From each ciliary ganglion, each short ciliary nerve innervates the respective sphincter pupillae muscle and both pupil constrict. Same side direct light reflex, opposite side consensual light reflex. AAPD, first, complete optic nerve loss. Normal side, both pupil constrict. Abnormal side, both pupil do not constrict. Number 2, RAPD, normal side, both pupil constrict. Abnormal side, on doing swinging flashlight test, both pupil will dilate. Yes. ARP, both the pupil are always constricted. It is a bilateral condition. It is a bilateral condition. No constriction, nothing whatsoever. Tonic pupil and pharmacological mydriasis, normal pupil always normal constricts. Abnormal pupil always dilated. One pupil always dilated. Whichever pupil is always dilated, that is the site of the lesion, everybody. I hope I'm pretty clear here, everybody. This is a revision of the pupillary pathway and its defects. 1 minute or less than 1 minute. If you have the pathway imprinted in your heads, everybody, you will be able to revise it very, very, very quickly, guys. Yes? Now, to finish this topic, everybody, let's see this chart. Let's see this chart on this word that we already know. That word is anisocoria. What is anisocoria? We already know. Coria means pupil, aniso means different size. If we want to define it, we say difference greater than equal to 0.4 mm between the two eyes in the sizes of the pupil. Now, this anisocoria can be divided into two. Let's see the right, the green colored arm first. Anisocoria greater in light. What are we trying to say? We are trying to say that the pupil size is different when light is thrown. That means when the pupil are in dark, understand, listen carefully, when the pupil are in dark, both the pupil are able to dilate. Okay? That means in dark, there is no anisocoria, both the pupil are able to dilate. Dilatation of both eyes is normal. But when you go out into the sunlight, one pupil is able to constrict, one pupil is not able to constrict. Am I clear? So that means the problem is in what, everybody? Constriction. So if the anisocoria is greater in light, that means the problem is in constriction. That is what is written here. Lesion ya abnormal pupil is the dilated pupil because the problem is in constriction. As the normal pupil is able to constrict in light, but the abnormal pupil is not able to constrict in light. Am I making myself very clear here, everybody? So normal pupil constricted, abnormal pupil not constricted. Dilated pupil is the abnormal pupil. Now, if such is the case, everybody, we see whether the pupil shape is normal or abnormal. If the pupil shape is abnormal, that means it must be a case of trauma to the iris, whether surgical or whether blunt trauma, but it has to be some kind of iris damage. Case closed, done. But if the pupil shape is also normal, but still there is anisocoria. One pupil remains dilated, cannot constrict. Then we have a lot of causes and we need to differentiate. So what we do is we start with diluted pilocarpine. Diluted pilocarpine as is written is 0.125%. Now, what is pilocarpine? What is diluted pilocarpine? Let me explain it to you. Pilocarpine, as you may know through your pharmacology, is a meiotic agent. Okay? Meiotic means something which will constrict my pupil. The normal concentration is 1%. Now, what do we mean by this normal concentration? That is important. That is what students can't wrap their heads around. Very easy. Normal concentration means in a normal person like you and me, let's say both of us are normal. I am normal. You are also normal, I'm presuming. If I put 1% pilocarpine, I will be able to constrict my pupil. But if I put 0.5%, that means lesser concentration, or I can say diluted pilocarpine, will I be able to constrict my pupil? No. You understand? The minimum concentration, the normal minimum concentration needed to constrict my pupil is 1%. Anything below that, a normal pupil will not constrict. Get this in your heads? Now, let's move back. So I am doing which test, everybody? Diluted pilocarpine test. I am using 0.125%. Again, my pupil, normal pupil constricts with 1%. Here I am using 0.1%. Will my pupil constrict? No. So I am saying no constriction. If there is no constriction, then I am happy or sad, everybody? I am happy. Why am I happy? I am happy because my pupil may be normal. But if my pupil constricts, everybody, to 0.1% pilocarpine, that means my pupil is abnormal. It has some disease. Which disease, everybody? The disease is tonic pupil. Pupil constricts to 0.1% of pilocarpine. I have tonic pupil due to the phenomena which is known as denervation hypersensitivity. What are we trying to say? The pupil has lost its nerve supply, short ciliary nerve, the final postganglionic nerve. The pupil has not been able to constrict for a long time, everybody. So the pupil is saying, I am desperate for constriction. Give me even a little bit of pilocarpine, I will promptly constrict. Or if I talk in pharmacological terms, everybody, there is mushrooming of extra receptors. So as soon as pilocarpine comes, it is able to attach to those receptors, and there is constriction even with diluted pilocarpine. This is called as denervation hypersensitivity. Because the nerve supply is lost, it is hypersensitive to pharmacological agents. So what is the way to diagnose tonic pupil, everybody? If I go back to the notes, you can also go back to the notes. So clinical feature number 1, clinical feature number 2, light reflex absent, near reflex present. Number 3, denervation hypersensitivity, or I can say constriction to diluted pilocarpine. Am I making myself very clear, everybody? Yes, sir. Done? Okay. Moving back, everybody. Now, if I was happy, that means I had no constriction. Then I said, let's test it further. Let's use pilocarpine 1%. Pilocarpine 1% is the normal constriction. My pupil should be able to constrict with it. I put pilocarpine 1%, but still both the pupil do not constrict. My pupil did not constrict to 0.1%. I was happy. But now that my pupil does not constrict even with 1%, I become unhappy. Unhappy because it should have constricted. But that leads to the diagnosis of pharmacological mydriasis, everybody. My pupil was under action of atropine, everybody. It cannot be reversed by a weak agonist pilocarpine, everybody. You understand? Pharmacological mydriasis. So if I go back to pharmacological mydriasis, light reflex is absent, number 1. Near reflex is absent, number 2. Number 3, does not constrict even with 1% pilocarpine. These are important lines. These can solve your questions in themselves. I hope you understand these two lines. Yes or no? Pharmacological mydriasis does not constrict even with 1% pilocarpine. Tonic pupil constricts to diluted pilocarpine. Okay. Now, lastly, if I put pilocarpine 1% everybody and my affected pupil constricted everybody, that means I had some other cause like third cranial nerve palsy. Third cranial nerve palsy also leads to mydriasis, but in that case, my pupil will be able to constrict with 1% pilocarpine. That is how we resolve the dilemma of anisocoria in light conditions. What about the second arm, everybody? Anisocoria in dark. Anisocoria in dark means in light both the pupil are able to constrict, but in darkness both the pupil are not able to dilate. One pupil dilate, one pupil does not dilate. That means in this case, which pupil is abnormal? The dilated or the constricted? Light, no. Anisocoria in dark. Anisocoria in dark, the dilated pupil is normal because it is able to dilate. The constricted pupil is abnormal. Pupil is the constricted pupil which is abnormal. Okay, everybody? Now, we do a test which is called as 1% apraclonidine test. If on putting apraclonidine, the affected abnormal pupil dilates, everybody. The pupil which was not able to dilate, if it is able to dilate, we call it a case of Horner syndrome. As simple as that. Horner syndrome we have already studied. If it still does not dilate, everybody, that means there is no disease. It is a case of physiological anisocoria. So basically, if there is anisocoria in dark, everybody, either it can be a case of Horner syndrome or it can be physiological, normal or Horner's. The only test which can differentiate 1% apraclonidine test. As simple as that. A lot of questions can be asked from this table, everybody. I hope you understand the importance of this flow chart and I hope you learn this. Okay. 3 takeaway points, everybody, from this chart. Main points. Number 1, pilocarpine diluted constricts pupil, tonic pupil. Pilocarpine 1% does not constrict pupil, pharmacological mydriasis. Apraclonidine test positive, Horner's syndrome. Am I clear? And that's all about the pupillary reflexes from my side. I hope you have been able to understand it. Again, I hope I have been able to break the myth of neuro being difficult. Pathway, once you understand that, you will be clear with everything, guys.